Good morning, ladies and gentlemen, dear friends, dear colleagues. It's my great pleasure to welcome you on a Boston Scientific sponsored session about the LAA closure. Completely different topic on the Congress, which is usually devoted to the TAVI and mitral tricuspid field, but there is a new concept that also some of us who joined that meeting may be interested in the LAA closure. So there is a track of the sessions about the LAA closure. One of the sessions is just here, and I will start just with some introduction. My name is Marek Grygier. I am interventional cardiologist from Poznań, Poland. And if you come here, you may expect that during that session, during that 1 hour, we will review the latest data on WATCHMAN and WATCHMAN FLX Pro. We may try to show you how to improve workflow strategies to improve our LAA procedures. So with using of a VersaCross, with Pro device, with a true steer, so steerable sheet. And also to understand some future direction with the LAA, with recent and upcoming trials which were published or will soon be presented. However, I'd like to start with that slide. For those of you who are not familiar with LAA closure, it's not something new, because with LAA closure there is more than 20 years that these procedures are done with a device which is definitely the leading on the market, with several trials which are presented here, starting with WATCHMAN Legacy, as we called that, WATCHMAN FLX, WATCHMAN FLX Pro, and we are waiting for the next generation of the device, so NG WATCHMAN. And if you look at that slide, you can see that several trials have been done so far, and moreover, there are hundreds of thousands of patients. In fact, more than 500,000 of patients had already been implanted with that device all over the world. LAA procedure is a simple procedure. It's a one-time implant, which is performed in cardiac cath lab or EP suite. It's performed by interventional cardiologists. That's why we are here. It's performed by electrophysiologists. And during that procedure, you advance the catheter to the left atrium for the puncture. We will see through the puncture of intra-atrial septum. You will see it just in a moment during the case. The procedure is done in general anesthesia or local sedation, and it is usually a short-time procedure. That procedure is safe. It's a main message among many colleagues. You can hear that, yeah, it's a very dangerous procedure. It's a safe procedure. You can see here the data from the SARPAS registry, and here are complications of that procedure. Pericardial infusion, less than 0.5%, device embolization, extremely rare, death related to procedure or stroke related to the procedure, extremely rare. And how that procedure is positioned in the guidelines. In Europe, we are not so lucky. In Europe, that procedure has a recommendation 2B class indication for patients who are contraindicated from long-term anticoagulants. However, in the US, according to the same data, that procedure has 2A indication, so for patients who are contraindicated for all anticoagulants, and moreover, as a 2B indication, it's a choice of you, and a choice of you as a physician, and a choice of your patient, if you want to have your appendage closed, or you want to take oral anticoagulants till the end of your life. And so far in Europe, we have these subgroups of patients which are treated and which are indicated. I'm showing you this data from the practical guide, which many of us sitting here on the podium published last year. So these are subgroups of patients who are treated now in Europe. But we are thinking that during that session, we will talk about broadening of these indications. I'd like to remind you that there is an app. You can ask questions during that session. We will try to answer. So if you want, and we want you to be as interactive as possible. Please ask questions. There will be a time for discussion. However, with that, I'd like to ask Ignacio Cruz Gonzalez to show us some data about the next generation LAA closure devices. Ignacio.
Thank you. So first of all, I must say that it's a great pleasure and honor to participate in this amazing session. And of course, I need to thank you, Boston, for the invitation. So I truly believe that evolution favors the survival of the wisest. And this is the evolution of the WATCHMAN device. You can see that it was launched in 2002, so it's a journey of over 20 years. The first generation of the WATCHMAN device, I was lucky enough to use it a long time ago. You can have only partial recapture. It was only a single row of anchor, and the end was open. So we always need to deploy from distal to proximal. A huge step in this evolution was the introduction of the WATCHMAN Flex. With this device, we can have full recapture and redeployment. We have a dual row of anchors, and we have a close end. So we changed the way we deploy this device because we have what we call the ball. So you can advance and you can deploy from proximal to distal or from distal to proximal. And to be honest, the results with this device are amazing. This is the initial study, the Pinnacle Flex study. You can see almost 99 success rate, very, very low rate of complication. You can see 0.5 and complete seal almost 90%. And also with this device, we were able to treat patients that were not suitable for the old device. This is an example, a case I did a few years ago. You can see here very low death and also very tiny morphology. So probably with the old device, we were not able to treat, but with the new Flex, we were able to deploy the device even we don't have enough space with the old device, with a very nice result, as you can see here. Despite these results, the company Boston designed the Flex Pro. And this design, the target is to optimize healing, to reduce the patient that we cannot treat, and improve, if possible, the seal performance. So what they changed in the device? So there are three important features with this new device, the Flex Pro. We have a new size, so we have the 40mm device, we have the HemoCode technology, and we have now 3 radiopaque markers. With the HemoCode, the idea is that this code is able to reduce platelet binding. Also, is able to reduce inflammation and is able to reduce thrombus in animal models. You can see here the difference between the device with the HemoCode or the device without the HemoCode. You can see a clear difference in endothelium coverage. So the final goal of this is to reduce DRT and probably change the therapy that we are giving the patients after the occlusion. I think that after this presentation, we are going to discuss different studies, so probably we are going to discuss the simplified trial design. Regarding the 3 markers, the idea is to increase visibility. So we have these 3 markers, as you can see there, at the level of the shoulder of the device. So when we deploy the device, this is a clear sign if we are enough deep or not when we deploy the device. So these new radiopaque markers help us to position and anchor the device. Regarding the 4mm device, is exactly the same. So the performance is supposed to be the same. We have the same compression range, and we have the same depth requirements. So now we can treat patients with an ostium larger than 30.5, and it's supposed to be around 5 to 10% of the patients that we were not able to treat with the previous version, and now we are able to treat. This is an example of a 40mm device deployment. You can see huge appendage. You can see here how easy it is to deploy, and also you can see the markers we can inject. So just with angio, you are able to see where are the markers, so you have a good compression. You are at the ostium, so you have nice result. So now I'm also going to talk about the new access system, the steerable seat, the True Stair. Each device performance has been improved on the access system. So you can see that there were different access systems for different devices. The idea of this, of having a new access system, a steerable seat, is because we want to improve our results. So we want to improve access, we're going to improve deployment control, and we want to improve confident release. Because you can see here that sometimes it's not so easy to reach the appendage in a coaxial way. Here you can see that although we were able to manage this case, we were not coaxial and it was quite difficult. So probably this new access system, this steerable seat, are going to make our life easier. And what is doing this device? So the idea of this new steerable seat is to improve seal performance, again to reduce the number of patients that we cannot treat, or at least make it easier, and of course improve, if possible, the procedural safety. So this is the new steerable seat. So you can see here that we are able to flex and make an extension of the device, and what is in neutral position is the double curve. So with this, we are able to control in 3 dimensions. We can make counterclockwise maneuver or clockwise maneuver to be anterior or posterior, and we can do flexion and extension just using this steerable dial that we have in the handle. So it's quite easy to manipulate, and probably with this it will be much easier to be coaxial, so we are going to be more precise. If we are more precise, probably our results are going to be much better. So we already have data. We already have data because in US, the Flex Pro was launched 2 years ago. The Flex Pro is available in Europe this year, and TrueSteer is also available since this week in Europe. So we already have the data of the HIL LAA clinical trial. So it was in US, 32 centers. There were 500 patients enrolled in the initial set, and after that there were 300 patients enrolled using the TrueSteer. And these are the results that are quite amazing, because the primary efficacy endpoint was met, so the rate of leak larger than 5 millimeters was 0% at 45 days. Also, you can see here the primary safety endpoint was achieved. It was a very low rate of complications, quite similar to the rate of complication that I have already shown for the Panacle Flex. And also what is interesting, and probably something related, that we are more precise and we have the hemocode, the rate of DRT is really low. So it's 1.6, just to make a comparison. In the AMULET ID trial, also done in US, the rate of DRT was 2.2. Also, we have the data in which we compare the cases that we did with the TrueSteer and the cases done with the fixed curve. You can see that the patients treated with the TrueSteer probably had higher stroke risks. Also, were more complex anatomy with multiple lobes, and these patients were more common treated just with DOAC alone after the implantation. Despite this, the results are quite similar. So we have similar procedural fluoroscopy and LAA dual times, quite similar between both. Also, you can see here that using the TrueSteer, the success rate was 99.3% procedural success, and what is more important, at least for me, there was only one patient in which the device was not successfully implanted. So it was only one that the investigator were not able to implant the device using the TrueSteer. Compared to the fixed curve, also the results are quite good, 96.4% success rate, but there were 9 patients that were not able to implant the device. So probably with the TrueSteer, although the anatomy were more complex, we are able to treat more patients, and hopefully we are going to treat all the patients with the combination of the TrueSteer and also the Flex Pro 40mm device. And the device here was quite similar. As you can see here, was quite similar in the cases treated with the TrueSteer and the cases treated with the fixed curve. Again, we need to remind that were more complex, multi-lobes, and larger appendages. And finally, just want to share with you the low rate of DRT. It was just 0.7% in the patients treated with the TrueSteer plus the Flex Pro. So for me, the WATCHMAN Flex Pro and the TrueSteer may establish the new standard of reference for LAA closure devices. Thank you for your attention.
Ignacio, thank you very much. Please stay or sit with us, and we have time for maybe 2-3 questions. Lawrence, maybe I will start with you. From that presentation on from the new features of WATCHMAN Flex Pro, if you would name one of them, which is the most important for you? The change in WATCHMAN Flex Pro in comparison to the previous version of WATCHMAN.
Well, not yet proven, but I have strong belief that the anti-thrombotic membrane will make a big change.
Okay. Sergio, a question to you. with the True Steer, which you have seen, you have a lot of experience not only with WATCHMAN, with the other devices. We had a steerable sheet also in the market previously from other companies, and your feelings with the new one and the previous one, what do you expect?
I think that this technology solves part of the problem of the alignment, because one of the main problems for a not good result are basically in two parts in the procedural planning and procedural execution. The first is the correct sizing of the device. The second is to get the best alignment between the main axis of the LAA and the main axis of the catheter. I think that this technology that we saw in the brilliant Ignacio presentation probably solve part of the problem. I think that we should use this approach for the procedural planning using the CT scan model 3D, just to check how is the position that fit at the better for the main axis of the LA. But this is the way for reduce the risk of misalignment of the device.
Mm-hmm. And Nina, one question to you. With these new markers on the WATCHMAN Flex Pro, you are an expert in TE imaging. Do you think that we will still need a CT assessment before, or we can become really coaxial thanks to these markers? What do you think?
I think the markers will help, but to be honest, if you really ask me what the specific features of fluoroscopy or CT analysis before is, I would say it's more the access way. Okay. Yeah, so this is something we can't really see with TE. So I think it might help, especially for people who want to learn the procedure. But CT will stay for the access way. Okay. So it's another question, but it has its
Okay, so let's move forward. And now I will ask Carsten Skirk. Let's see a recorded case of LAA closure with WATCHMAN Flex. Carsten.
Yeah, good morning. Thanks for having me. And it's actually pretty nice to present this case because it builds on the former presentation by Ignacio. So we have different workflows in the CAS lab, and appealing is to have CT for pre-planning, then do the procedure with the conscious patient in the CAS lab together with ICE, and then do the follow-up with CT imaging. We know that CT is really sensitive for detecting DRT and leaks better than TEE. But because of different considerations, the normal workflow is you have a TEE, and you can have that for pre-planning, but usually the procedure is done with TEE under conscious sedation, and the follow-up is done by TEE as well. And this has some disadvantages, and therefore ICE actually is preferable. The disadvantage of ICE is that it's really expensive and there are reimbursement issues, but advantages, you can speak with the patient on the table. It's like a coronary angiography. You don't need conscious sedation, and you don't need an anesthesiologist if you do it in intubation. And you don't have an elevated risk for aspiration pneumonia, especially in older multimodal patients, where the TE is risky for these patients. So the case is a 66-year-old male with permanent atrial fibrillation, status post-stroke 4 years ago, arterial hypertension. He has AV malformation and therefore several major GI bleeds, and he's status post-biological aortic valve prosthesis because of a bicuspid valve. So a patient with a SATS risk of 4 and a aspect of 3, of course, is a candidate for LAC. And we did a pre-planning CT that you can see here. It's rather small, LAC 12 by 18 millimeters. And the anatomy is a little bit challenging. We can discuss this afterwards. You see here that the LAA is it's not going off really anteriorly, and you have some weird angles from the fossa ovalis to reach the LAA ostium. So with pre-planning software, you can basically digitally implant different devices in different positions. And you see here that a WATCHMAN FLX Pro 20 millimeters distally implanted seals the LAA, so there is no leak. And you even could, and that's the advantage of the device, implant a 24 millimeter device, but you would have a small shoulder there. And therefore, we decided to implant it distally and use a 20 millimeter device. So pre-planning includes the septal puncture site as well. So we can see here that regardless where you puncture, you will have a huge angle to the LAA center line. But it clearly shows that you should use a posterior and an inferior or mid-septal puncture site to reach the LAA. But nevertheless, you won't be in perfect alignment with the LAA center line. So now we basically know we would like to use a 20 millimeter device, and just for reason for discussion afterwards, I show you that the TrueSteer was not available. It's available this week in Europe. So we used an FXD curve sheet and the VersaCross Connect. With the VersaCross Connect, you can pre-bend your sheet. You just exchange it. And in the right bottom picture, you can see that it's pretty easy. You have the VersaCross wire, your FXD sheet with the VersaCross connector. And then you just puncture. Of course, you can do one side or both sides. We usually do both sides, 12 French for the ICE catheter, and then on the other side, your delivery system. And then you just, advance your ICE to the right atrium. And once you are there, you look for your home view with a tricuspid valve. And then you advance your sheet, adjust the VersaCross wire, and then you just put your eyes in the position, and you can have, that from TE basically a bicable and short axis view, where you see the septum from the right atrium. And then you go down with your sheet into the fossa and you see your tenting. So here we have a rather posterior and mid-septal puncture site, really important for the further discussion. And with the VersaCross wire, you can then easily puncture exactly on that location you chose, and then you basically dilate your puncture site with your sheet. You don't have to change anything, and you go then through your dilated puncture site. You see here your wire in the eyes, and then you just go through the puncture site and you are in the left atrium. And then you basically can guide your procedure with your ICE probe in the left atrium. And can, look at your LAA ostium. And so now we see here that we had some difficulty to reach the LAA, and therefore a steerable sheet. Usually you wanted to do the procedure with a true steer, but there's another polar sheet in the EP world made by Boston, and that's steerable as well. And with this steerable sheet, it's easy to reach the LAA. And now, of course, you do your measurements. It's pretty much the same as CT pre-planning showed, so no surprises here. You can do the same with your ice probe in 3D MPR, as you are used to have in your TE fuse. You can measure your ostium, and now you have to exchange your polar sheet, which true steer you don't have to do. True steer you can directly implant back to the FXD curve, and then implant your device. So here you have the pre-planning, and here you have your device sitting distally. And as I showed you, you could use a 20 and 24 millimeter device, so we used the 20 millimeter WATCHMAN Pro. Here you see your markers, and if your markers are aligned, then you can measure first the tug test, and then you can measure basically your compression, which we did. Imaging in ice, you see your device here, here, and it's at the ostium and looks nice. So compression, I told you if you are aligned with your markers, you can measure the compression. It's 25%. It looks like this. I like to oversize a little bit all the time. And final step is then to look for leaks. There are no leaks at the device. And then you are done. And basically, what this case illustrates that even if you think that it's an easy case, it can get a little bit more complicated. You have now the possibility, starting this week in a pre-market release, to have the TrueSteer delivery system with VersaCross Connect for really safe interatrial septum puncture with one sheet and one wire. So this is really safe and efficient. The steerable sheet is really good for complex anatomies in order to help align your device with the center line of the LAA. And we spoke about that. The WATCHMAN FLX Pro may shorten the need for intensity or time of post-procedural antithrombotic therapy. And with the Closure F study, we just showed that that is really important to do that. So we have new technology to shorten the intensity and time of the antithrombotic therapy. And still, it is really important, and keep that in mind, to have the optimal transeptor puncture site located before your procedure. Thank you very much.
Carsten, thank you very much. Excellent case, excellent example how the new workflow in our cath lab looks like. Maybe I will start discussion, Nina, with you. How you see the role of ICE imaging in these procedures? In other words, who will be operating the ICE machine? You as an experienced operator or interventional cardiologist should do that? There are different strategies. What is your opinion?
Well, I think at the beginning it might be most likely that the imager is running the ICE probe, or at least the interpretation and the dealing with the machine, with the echo machine, will stay in the hands of the imager. So it's still a combined procedure. So if you have a lot of experience, some operators do it themselves, the steering. I know, Sergio, you do it, Carsten, you do it. You steer the ice probe by yourself. And I think it's a good combination, but you need an imager on the echocardiographic side. Marek, there's an interesting question because the auditorium really observed the case closely, Carsten, and there's a question coming actually from two different person here in the auditorium. Do you think the transeptal puncture side in your case was a little bit too high?
Definitely. Definitely it was too high. More inferior would have helped. But so that tells you that it is forgiving for a steerable sheet. But here you could see that without it, it would have not be possible to reach the LAA ostium. So farther inferior would have been easier, definitely.
And Sergio, in your cath lab, because Sergio and then I ask Ignacio, with the eyes, how you are now approaching your procedures? All procedures are done only with eyes, or how it looks like in your lab?
In our lab, only eyes with local anesthesia. And just to reconnect with what Nina was saying, the involvement of the imager in the procedure is essential because the interventional cardiologist is, of course, very expert in catheter manipulation, but the know-how of the imager for managing and elaborate the imaging, in particular, if you move to the 3D, is essential. Because when we decided to involve an imager in the procedure, we observed an improvement of the quality of the imaging that we are able to obtain. But just a comment on the case. It's a very interesting case because it's an example where the innovative technology are extremely helpful for getting an optimal result. We had a pre-procedural planning using a mathematical model to predict the result. So the correct sizing, the correct position of the device, a new imaging technology that provides with the patient in local anesthesia all the information you need with an excellent visualization of the anatomical structure for guidance, the procedure, etc. And finally, the use of the new device technologies. With a new device, with a new steerable catheter, all these aspects are key of success for the procedure.
Ignacio?
Yeah, in my lab, we are using micro or mini T probe for the last probably 7 years, just with local anesthesia, mild sedation. So the workflow in our center is CT pre. We perform the procedure under micro T or mini T guidance and same-day discharge because you don't need general anesthesia. It's only venous access, so that is how we work. And regarding the case, I really believe that Sergio made a great point. I mean, it's the combination of technology because with the Flex or the Flex Pro, even if you are not perfect in the middle line or coaxial, you can get a nice result. With other devices, if you are not perfect coaxial, it's quite difficult. And also, a key point is transeptal puncture. Because the true steer or any steerable sheet are not going to correct your transeptal puncture. It's going to help to be more coaxial or be more precise, but it's a key point that we need still to focus on transeptal puncture.
So you have heard two ways of doing that. One with eyes, the other one with mini T or micro T. And Jan, in your lab, how it looks like?
Well, I'm a
From a poor country like UK?
Yep, poor country is slightly different at the moment. It's single stop. Patient comes with clinical indication, and we do sizing with theory on the table, implant device, which is the way how to save beds, etc., etc. Bottom line, this procedure is developing. There's more operators coming in. We will hear studies, EP people, structural people. We need to make sure it's a safe, good outcome. So it might not be universal solution for each individual hospital, each country. Bottom line is safety. In expert hands, this is preventive procedure. We need to have the best possible result. I look forward to have the steering which will stop needing my nerves rotating. So I really look forward having hands on it because it looks like another simplification. But poor country, one day stop, all sorted in one day.
And Lorenz, I will finish with you.
You want to say rich country, but we cannot afford ice in all procedures. We do like 150 a year, and for that we bought actually a mini TE. It's like equivalent to 15 eyes, and with that it works perfectly. Mild sedation, mini T, quality is perfect with a good imager. You can really streamline, but 100% VersaCross, because the puncture is essential, as you have shown, and I think the time is over for a needle-based approach. You really need to be precise and limit the risk of pericardial effusion during transeptal puncture. So I really believe VersaCross makes a big difference, and now with Connect, even more efficacious.
Yeah, okay. Carsten, VersaCross, Connect. Do you think that these new developments will really change our field?
Yeah, it's the same as in rich Switzerland. We use VersaCross for all procedures now because it's just so much easier. And you saw that you basically need one sheet and one wire. That's all you need for the procedure. You don't have to exchange anything. And every step in exchanging sheets has a small risk of air emboli. So this is one big advantage. And the second one is that with this system, you, even with complicated septal anatomy, so floppy septum, so you are really safe because there is a lower risk for perforating the LAA roof if you puncture. So it's a really precise puncture modality, and therefore we use it in every case now.
Yeah, okay, let's stop the discussion here. I think that I was if I can comment about the VersaCross, I was quite skeptic at the beginning. What for I need a VersaCross? We have a standard sheet to puncture, it's easy. But with VersaCross, the easiness of doing that and safety, what Carsten has mentioned, is really key. We have to move forward, and I'd like to show you, we are on interventional meeting. However, I'd like to show you probably the most important trial which was published last year, and then subsequent data were also that year about the option trial. And to stop thinking that the trial is only for EP guys, no, that trial is for us interventionalists. So that publication, it was the end of 2024. What is the option trial? It's a huge randomized trial in which, in patients after AF ablation, these patients were randomized to receive or continue treatment with oral anticoagulants, or to have the left atrial appendage closed, and then there is a short period of treatment with oral anticoagulants. And there was a 3 years follow-up, and moreover, that procedure, the LAA closure with ablation, could be done as a concomitant procedure, and, however, could be done also as a sequential procedure. So 40% of the patients had done it on the table by electrophysiologists, but 60% of these cases were done as a sequential, so 3 to 6 months after the ablation. And these procedures were done mostly by us, interventional cardiologists. And there were primary and secondary endpoints. I will discuss them later. So typical population, maybe not so high-risk patients, slightly younger than a typical population for patients for the LAA occlusion. However, the success of the procedure was also quite high, as you can see, almost 99%. What about the primary efficacy endpoint? So the question is, if instead of oral anticoagulants after ablation, can we, instead of oral anticoagulants, close the left atrial appendage, and is this as effective as the other treatment? As you can see here on that slide, these two treatments are equal. There is no difference regarding to stroke mortality or systemic embolism. Moreover, in the trial, if you look at some endpoint outcomes, what is here quite important is that the ischemic stroke was exactly the same on both arms. There were in the past questions raised that probably, yeah, you are closing the left atrial appendage, you are reducing the rate of hemorrhagic stroke, but the ischemic strokes are higher. No, it's not true. In the trial, it was shown that they are exactly the same. And what is the second endpoint, which is quite important here, that if you close the left atrial appendage, your patients will bleed less than patients who are continuing on oral anticoagulants. You can see that there was almost 60% relative risk reduction in major and clinically relevant bleedings not associated to the procedure. However, even if you take into account the bleedings related to the procedure, there was still a significant difference in favor of the LAA closure. The differences were exactly in all these groups. The study results were exactly the same. However, there was also the second paper published this year looking separately on both these subgroups of patients treated as a concomitant or as a sequential cohorts of these patients from the trial. And what you can see in that concomitant subgroup of patients, primary efficacy and primary safety are exactly the same, but that part, I would say, is more for electrophysiologists, but that part is for us. So interventional cardiologists. If you look at sequential procedure, the efficacy and safety is exactly the same. So, in other words, if you have a patient, there is a very active program of doing ablations at your site. Try to discuss with your colleagues, with EP colleagues, yeah, there is a trial which showed the data which I just presented. We can start collaboration. We can teach you how to do this LAA closure procedure during the ablation, or if there is a reimbursement issue, remember that we can try to collaborate and think about doing these cases as a sequential one. So 3 to 6 months after AF ablation, we can go ahead and try to do the LAA closure in that subgroup of patients. So these are the results of the trial, and I will stop here, asking a question maybe to some of you from the panel, how it looks like in your center. Lawrence, I will start you. You have already taken the microphone. How it looks like in your center with doing these patients after the option trial?
So, I mean, one consideration is the tariff that is provided in your country. We just got a tariff now for combined procedures, and that's why we joined the teams. We work collaboratively with the EP colleagues, and whenever we do a risk stratification by CT, which is anyway done prior to PVI, and there we look at the anatomy, and if the anatomy is not very challenging, we opt for a combined procedure where the interventional cardiologist actually joins the EP colleague. Of course, that will depend on the individual experience the EP person has, but in Bern we do that jointly together, and only in case of more complex settings we decide to go for a staged intervention. But obviously the precondition is that it is paid.
Yeah, it's in Switzerland it's paid. Jan.
Just be short. Our EP doctors who are not done started training in how to do ablation, and I'm slightly provocative, and Horst Sievert would agree. Actually, structural doctors started learning ablation because having Farapulse on ice, so I can imagine there'll be some interdisciplinary development of a skill. So currently we plan it because it's not funded as a double, but we are training people from those respective specialties.
Mm-hmm. Any other comments from this side? Ignacio?
Yeah, we participate in the trial, and in the trial we did most of the cases sequential, but now we are moving, but we are doing the cases. What I'm trying to say is that when they have the puncture, they have the wire in the left upper pulmonary vein, it's quite easy for us to go there and do the case. So we are moving from sequential now to combine in the same procedure, because now I really believe that they feel that it's a safe procedure. We are not going somehow to make any problems in their procedure. So they are happy to welcome us to their lab to do the case when they have finished the ablation.
Mm-hmm. And Carsten, I will finish
And in
with
Germany,
you.
it's not reimbursed yet to do it combined, so we do it sequential.
The sequential, yeah. So as you can see, two ways of doing this procedure. In some countries, it's possible to do as a concomitant, US, Switzerland, I don't know if somewhere else. But in the other countries, remember, these cases could be done as a sequential cases, and start the collaboration with your EP colleagues. There is a huge number of patients who could be treated. We have to move forward. Jan.
Okay, so see, all of you obviously means the future of appendage closure is bright. So we know the evidence, obviously with a lot of studies, it started Protect AF, that WATCHMAN old version works better than warfarin, which was then validated Prevail. Then we look more into patients who were kind of non-inferior to DOACs, because the original study is only warfarin, and we just had an option. So there is already, but there are limitations, because early days we as a doctors had to learn the procedures, so there were some risks, 5% effusion, early studies, procedural stroke. It's much better since, because experience grew to hundreds and thousands of individual centers and a relatively small sample size. So option, again, we discussed, it's slightly specific subsets. So there are a couple studies which were presented as of the press last week, AHA, which I mentioned briefly, the patient who were ablated, and then this was more how often your arrhythmia occur and whether you actually need any anticoagulation, which obviously secondary indirectly could suggest whether you still need to close or not. So in that study, we saw that actually despite the ablation success, there was no decrement in the risk of stroke or embolism. There was slight risk of non-major small bleeding during procedure. So again, it's no definite solution, even ablation is successful. Overall, we learned it's very safe. When you do ablation, the risk of stroke is very low, and is actually lower than threshold which we are using for various risk CHAF fast definitions, etc. So same time, in some cases, you might not need continuation or so while we are proceeding, the ablators are proceeding as well. So now it's question back to, as we see in the option, which patient then we need to subselect. So heart-brain meeting or structural and EP meeting still allow very well with body of evidence which we gathered. Another study perhaps created some steer, was very broadly defined historical study of closure AF, which was intending to be non-inferior when you do appendage in a broadly selected patients with composite point of stroke, embolism, cardiovascular death, and bleeding. So we didn't reach quite target, but we still learned a lot of very good lessons. We learned, is a historical study, there was rather a lot peri-procedure bleeding. Again, we are much better than that. So it again shows that we need to move on in our studies with latest technology and getting more answers. What was definition of cardiovascular death? And again, we know that impact of procedure, we learn from Protect original studies over the time, because it's a lifetime protection. From appendage, you don't need anticoagulation, because your anticoagulation risk you carry with you for the rest of the life. So what we need to do to implementing this wider, we need to make sure the benefit in terms of preventing stroke and preventing bleeding, it's balancing risk of complication. And again, for that, we got all those exciting studies which are covering broader risk. High risk patient is a LAAOS IV for patient low risk, and that's the study which might change the scene, and appendage might become fifth valve on this meeting. And then whether we can simplify after successful appendage closure our medication. So LAAOS is building on the success of LAAOS III. As you know, it's surgical, it's well-established therapy. When you do surgical operation, you take appendage out. So it's a question whether we can do same if you do it percutaneously. And we also know there is still a group of patients with AF which, despite anticoagulation, have risk of another stroke, another ischemic stroke. So we need to find out whether appendage closure on the top of it can justify that. And we know this patient, again, as I said, higher risk, 30% of the patient go to higher risk from CHAF definition. So their risk of stroke is not negligible. Again, so it is actually investigators-run trial from Canada, large group up to 4,000 patients, and again they are allocated to either WATCHMAN Flex and anticoagulation or anticoagulation alone. So this will again expand whether actually combination of both things in a high-risk patient will be some benefit. So we are waiting for the study, which is ongoing. Outcome will be defined when we reach event-driven number of patients in that high-risk group. So there's one study which might be significant contribution and since changing. Second one is just to simplify post-procedural anticoagulation. Professor Cruz already mentioned. So whether what you do only aspirin or reduce NOAC or very good adapt. So and again we'll be studying composite endpoint of death, stroke, systemic embolism and bleeding in 6 months and secondary after 12 months. So it will tell us whether appendage itself can a simplified regime after, again, avoiding any risk of bleeding with anticoagulation or anti-aggregation. And here you see the study run. Again, it's a large study, so it'll be up to almost 2,000 subjects. So the body of evidence will be vastly bigger once we are ended of those studies. And finally, the biggest one, and I think 2026 might just be a year of appendage closure, is Champion AF. It's the patients who are like primary indication is got non-valvular atrial fibrillation in absence of any valve disease or mechanical valve. CHADVAS is relative average for men 2, for women 3, and patient can have a NOAC. So basically patient come to your office and theoretically offer either you have a closure and you got some simple medication like aspirin, or you have a closure. Large study, US plus a lot of European centers, 3,000 patients. So we are into almost end of the follow-up of those patients. So they were randomized 1-to-1, they receive WATCHMAN Flex, and other patient is on NOAC. Primary endpoint is non-inferiority for all stroke, cardiovascular death, and embolism within first 3 years. There are safety endpoint for non-procedural bleeding, again in comparison with anticoagulation. And third, efficacy is to be same for prevention of ischemic stroke at 5 years. So we'll see those data later. Again, here you see the flow of the study. It's very labor-intense study. It's a brilliant study, but as I said, it will be very hard to find that evidence once it's out. Just for comparison of historical trials, we are talking really thousands of patients. So from smaller groups and historical, Protect, warfarin, etc., hundreds, Prague study, we are talking to thousands of patients. So whichever evidence comes of it will be very serious and it might change the scene. So what we hope achieve there from LAA beyond bleeding risk, improved quality of life, reduction of stroke incidence and severity compared to anticoagulation, mortality reduction, cost reduction, especially drugs. In some markets, lifetime drugs is expensive. We can have measured some public health impact, whichever health system you work in. And obviously, we learn a lot of continued examination of LAAC, so there'll be a lot of vast body of knowledge about safety procedure. So watch for it. I think appendage is becoming fifth valve, so we'll see a lot more of it in years to come on London Valve. Thank you very much.
John, thank you very much. So as you can see, there is a lot of studies which are ongoing. The body of knowledge will definitely increase. So we are waiting for the Champion AF. So one way of study is if we can implant or close left atrial appendage instead of oral anticoagulants. It's one way of study, so it was option. Now will be Champion. And we saw the next group of studies if adding LAA closure device over oral anticoagulants is another way of approaching. One short comment about that trial.
Mark, we have a question from the auditorium. Yeah, please.
Hi, Casper from Aarhus. A great presentation. Many of these studies that we include patients in have a criteria about survival that predicted survival should be 1 or 2 years to overcome the procedural risk. And I would like to discuss that with you, but from my perspective, I think we need to be better also in light of Closure AF to objectify this, look at clinical frailty score, which comorbidities should we disqualify patients for the procedure, when does it become a futile procedure?
I think it becomes very much like what we do in TAVI field. You got heart-brain meeting or appendage meeting, and those factors will be factored as evidence comes, of course. So individual decision will be based on evidence, but you take those other factors. Again, valve meeting, some TAV is futile, it might be appendage. So you need hard-brain team to decide. Yep.
Carsten, any final comment from your side?
Yeah, I completely agree. So in closure, we included really high-risk patients, and as you know from the Schanzowski and Haas-Bled, high risk means old patients because age is a big contributor. And we observed a high mortality rate, overall mortality rate in these patients that were followed up until 7 years. Maximum. After 3 years, 30% were dead, 30% of patients. That is only half the story, and I would say that we really have to rethink, and CHAMPION will be a big part of it. What is the right population risk-wise that benefits from LAA closure? And I guess that's what the question is about. So we have now a study in really high-risk patients that is not as positive, to put it mildly, and we have a study in low-risk patients, which is option. You can draw a lot of, they have a low risk for major bleeding, so LAC is not reducing major bleeding in these patients. And now we have the medium risk patient population, and that is CHAMPION and CATALYST. And it's really interesting to see whether that is the right population to close the LAC. But yeah, I agree, we have to think about which patient population is the best one and gets the best benefit of it.
Okay, we are running out of time. We could go ahead with that discussion about the closure AF and other trials, but I think finishing that session, I think that you have a chance to review the latest data on WATCHMAN Flex. We are able to observe how the new strategies or workflow should look like, and you may understand how these the new trials will change the field. However, I'd like to finish with that slide. So far, the most important thing is to increase therapy awareness. So even in Europe, with the indications I like here, taking into account that maybe treating the too sick patients is not a good option, think if your patients are patients who could be treated and who may benefit for the LAA closure. With that, I'd like to thank you, all the panelists, and especially you who came to that session. I'm very happy that the LAA closure session was very well attended here. And I'd like to invite you, there are another session, another Boston session. It's in the afternoon about the LAA closure with excellent speakers. Jens-Erik Nielsen-Kutsk will lead that session. John Kem will also join that session, and other distinguished speakers. So please come also to the other session on the LAA closure. And thank you very much, and enjoy the rest of the Congress.